Hello everyone, my name is Jonathan Halim. On behalf of my colleagues, we would like to thank SAGES for the opportunity to present our work. I have nothing to disclose. I will be presenting a randomized trial comparing the effects of three forms of feedback: video feedback, verbal feedback, and self-assessment on simulated laparoscopic skills in a novice population. Globally, access to surgical care is limited. The process of surgical training is difficult, especially for complex laparoscopic skills such as laparoscopic suturing. Lancet Commissions for Global Surgery 2030 has identified the need to scale up surgical, anesthetic, and obstetric providers, especially in developing countries, and for developed countries to continue strengthening training and professional development. One way to do this is to improve the way feedback is given. Current evidence has seen the use of video feedback and self-assessment in other sectors such as sports and music. In surgical education, there is also a potential benefit for technical skills acquisition. However, conflicting results remain in the literature, likely due to the problem of a lack of standardization when delivering feedback. This problem is also noted in earlier studies. The aim of the study is to establish the most effective form of structured feedback on laparoscopic suturing skills performance in novices by comparing the effects of expert verbal feedback, video feedback, which involves video replay with expert verbal feedback, and self-assessment, which requires trainees to objectively assess their performance based on video replay. This study is a prospective randomized blinded trial comparing the three groups. Participants were tasked to perform laparoscopic suturing with intracorporeal knot tying. They were given a maximum of 2 hours to practice the task 3 times, and a pre-feedback assessment was taken to quantify their baseline performance. Participants were then given feedback according to their randomly allocated group, and after feedback, participants were asked to practice the task another 3 times and were given a maximum 1.5 hours to do so. They were then asked to perform the task once within 10 minutes, just as in the pre-feedback assessment, and this was marked as the post-feedback performance. The OSATS assessment tool for laparoscopic suturing, adapted from the Royal College of Surgeons, was used as the primary outcome measure. We compared the pre- and post-feedback scores within groups, and also compared the score improvements between groups across the board. A post-study questionnaire was also used to measure how participants felt in terms of their confidence in performing the task before and after feedback, the knowledge for improving their performance, and their experience on the structure of the training session. Moving on to the results, the demographics data showed no significant differences in sex, age, handedness, or training level of participants across the three groups. By comparing pre-feedback and post-feedback performance, verbal feedback showed a 6% mean improvement, which was not statistically significant. The video feedback group showed a 16% mean improvement and self-assessment 8%, which were both statistically significant. Comparisons of performance improvements between groups showed that there were statistically significant differences. The video feedback group improved significantly more than the verbal feedback group. The performance improvement in the self-assessment group was similar to the video feedback group. However, it was also similar to the verbal feedback group, suggesting that the improvement lies between that of the video feedback group and the verbal feedback group. There were no significant differences in the questionnaire outcomes across the three groups, as the period of the study was short. However, positive results were observed in terms of participants' confidence, knowledge, and overall experience of the training program. Simulation-based training is used extensively in training surgeons. Feedback and coaching is routinely delivered during these sessions. We want to improve the way feedback is given so that it can be given effectively, which will shorten learning curves. Video feedback and self-assessment utilizes visual cues and makes use of audio-visual technologies, which will provide a retention rate of 20% according to the learning pyramid, twice that of a standard lecture or textbook-based learning, akin to the passive learning received from verbal feedback. Furthermore, video feedback and self-assessment stimulates reflection and discussion, potentially further raising the retention rate to 50%. All forms of feedback comprise some innate value. This can be seen even in the verbal feedback group, where there is a small margin of improvement, albeit statistically insignificant. Video feedback and self-assessment both showed positive and significant results. They are to enhance skill acquisition. Video feedback from an expert represents external feedback, and self-assessment represents internal feedback. Both forms of feedback are important in the development of surgical skills. The Royal College of Surgeons' Basic Surgical Skills course involves expert feedback from faculty members, as well as requiring participants to reflect on their own performance. This study, however, is limited by a short period. Future studies should look at the long-term effects of these feedback techniques and how it affects trainees' learning curves. It's also important to note that the accuracy of self-assessment increases with age and experience. The ability to self-assess might increase as trainees progress in their career, compounding the benefits of self-assessment. In conclusion, the greatest benefit should be seen in combining both techniques. By utilizing video-based technology, expert feedback, and self-assessment can be combined and incorporated formally into the way feedback is delivered on surgical training curricula. This should hasten the learning process in surgical training, which should also alleviate the current healthcare demands and pressures, and it will take a step forward in reaching the Global Surgery 2030 goal. Thank you very much.